We are live now. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar, episode 31 of Amogs Emergency Obstetrics Committee with Ksoga. So it's my privilege to introduce the convener of today's webinar, Dr. Sonia Batra ma'am. Ma'am is the Secretary of Karnataka College of Obstetrics and Gynecology, Advisor Safe Motherhood Committee, Ksoga, Advisor Breast Imaging Committee, Ksoga 23 to 25. I welcome you, ma'am. And it's my privilege to introduce the coordinator of this webinar, Dr. Anita ma'am.
Thank
Ma'am
you.
is Assistant Professor, MR Medical College, Kalaburgi, and also
Thank you.
Treasurer. So I welcome you, ma'am, and I hand over the session to you.
Yeah, thank you, Sahiti. Good evening, everyone. Amogs and Ksoga is we are conducting this webinar, and I think probably this is in this session. I think we are doing it as the last session, and hope to do again many more such academic fests weekly, monthly, and with all the coordination and cooperation of Amogs and Ksoga. So to begin with, I request Sahiti to put up the welcome clamp 90 video. Sahiti.
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः कल्याणम् आरोग्यं.
Thank you. Thank you. To begin with today's evening, I welcome all the Ksoga office bearer and the Amogs office bearer. I welcome Dr. M.G. Hiremat sir, Chief Patron Ksoga, Dr. H. Nagraj sir, Patron Ksoga, Dr. Bharti Rashekar madam, President Ksoga, Dr. Vidya Tobi ma'am, immediate past President Ksoga, Dr. Rajashri Paladi ma'am, Honorable Secretary Ksoga, Dr. Suman S. Gaddi ma'am, Honorable Treasurer Ksoga, and Dr. Durgadas Arsana sir, President-elect Ksoga. I also welcome the Amogs office bearers, Dr. Kiran Purpoti sir, President Amogs, Dr. Bipin Pandit, Secretary General Amogs, Dr. Rajendra Singh Pardeshi sir, immediate past President Amogs, Dr. Madhuri Mendale ma'am, Treasurer Amogs, and Dr. Sneha Buyar ma'am, Amogs Chairperson Emergency Obstetric Committee 2024-26. I request Dr. Bharti Rashekar ma'am to kindly invite today's chief guest and the guest of honor and also the speakers.
Thank you, Dr. Anita, and my pranams to all the esteemed faculty from Foxy and from Ksoga. Wishing you all a very good evening. And today we are on a very important webinar, and Dr. Sonia and Dr. Anita have very well convened the whole program. And I extend a warm welcome to the President of Amogs, Dr. Kiran Purpoti, and Dr. Rajendra Singh Pardesi for gracing the occasion. And Dr. M.G. Hiremat sir and Dr. Basuraj Sajjan are busy and they have expressed their inability to be here. We extend our pranams to them also. And we have our very eminent...
Both bring me some lunch.
As Dr. Megha Kamlapurkar, a dear friend and Kasogian of ours, who will be speaking on the venous thromboembolism in pregnancy, which is a very common situation but not often addressed in the proper way. She will be enlightening us, and we have Dr. Vidya and Dr. Sunanda who will be chairing the session. Welcome to both of you, madam. And then we have another important session which Dr. Sneha Boyad will be speaking on. She will be speaking on cholestasis of pregnancy, which will be chaired by Dr. Shobha Shirgur and Dr. Shashikala Gubri. We thank you, madam, for accepting our invitation of this very prestigious webinars we have been holding as a series between the Amogs and the Ksoga program, which has been very fruitful. And we have all our Dr. Vidya Tobi and Dr. Kasturi Donipat are just jumping from one web to the other web, and they will shortly come back like Spider-Woman, I would say. They will come back. And then Dr. Durga Das is always there with us, the President-elect, and already ready to take over the reins and have a very fruitful year for Ksoga. And we thank you, Dr. Durgadas, for being here. And I would like to thank the entire Amogs team Dr. Kiran Kurtukoti, Dr. Rajendra Singh Pardesi, Dr. Bipin Pandit, who is the Secretary General, and Dr. Madhuri, who is the Treasurer, and Dr. Sneha Buyar, who is in charge of the Chair for Emergency Obstetric Committee. And Dr. Sneha has very aptly chosen these topics of medical thromboembolism and cholestasis in pregnancy. We have just had the liver day just completed yesterday, and she has very well chosen this topic. And I think looking after the other organs in pregnancy, other than just looking at the baby and the uterus and the placenta, I think we have to be aware of all the other emergencies we could come across in pregnancy. And very often in our clinical practice, when we get a case of any liver disease or acute fatty liver or even a venous thromboembolism, we either have to go back to our textbooks or go back to our guidelines and try to give them the best care. And I'm sure today Dr. Megha and Dr. Sneha will do an excellent job in enlightening us and updating us on what are the recent management guidelines of these not very rare problems which we do come across in pregnancy in the private sector and the public sector. And I thank Dr. Sneha for getting all of us together on this platform. We know that Maharashtra and Karnataka, we are like sisters. We are not only neighbors, but we are also like sisters. And we both are quite a huge population of the Foxy comes from Maharashtra and from Karnataka. So we contribute to the Foxy also. And at this opportunity, I would like all of you kindly support Dr. Sneha Buyar for the vice presidentship of the West Zone. The elections are fast approaching now, August 1st to August 10th. I request all of you to please vote. Please exercise your vote. Dr. Sneha has been a wonderful academician. It's not just for the election. She has been working from a very small town in Maharashtra, but she has come up and academically she is very strong, and I know she is going to serve the Foxy very well, and we need to support her this time. Last time, unfortunately, we don't know, for unknown reasons, we could not see Dr. Sneha as the vice president, but this year we definitely want to see her, and she will definitely do justice to that post, I would say. So please, for Ksogians and the Amogs members, please do exercise your vote and vote on the first day itself. Because what you will say, I'll do it on second, I'll do it on third, I'll do it on fifth, and some emergency, something happens, and unknowingly you have missed that valuable strength of yours. So I request you, and at the same time, I would like to tell you that from Karnataka, I am contesting for the Perinatology Committee chairperson, and this election will be from August 16th to 25th, and the president and secretaries will receive the link, and you will have to vote for this. Again, I advise you that please do vote for us, and we request you, your vote is our strength. I would like to tell you here that yesterday my granddaughter, who is around 9 years old, she is very fond of doing posters and flyers on Canva because they have it in school. And she said, Aji, I want to do this something perinatology you are doing, because she hears us talking. So she said, I will do a flyer for you. I said, fine. And that flyer, she just put, your vote is my strength. I have not told her. She said, I'm going to put this ballot box there for you, Aji. And she has made it for me. So I think rightly they have told us that your vote is your right and my strength and our strength. So kindly vote for us, and wishing this webinar a great success. And Sneha, we are with you. Please take rest and take care. I know you are straining yourself a lot. We do feel worried for you sometimes. Please do take care of yourself also. We all will work together for the betterment of women's health as Foxians, as Amoxians, and as Ksogians. And over to you, Dr. Anita, to carry on the program.
Thank you so much. Thank you, dear Bharti. Thank you so much.
Thank you, ma'am, for enlightening us so much for the exercising of votes and all about your granddaughter. Thank you very much, ma'am. Moving on, I request Dr. Sonia Mandapa, ma'am, to please take over the scientific section for today's evening.
Please check whether Dr. Kiran Kurtakoti, President Amogs, have joined, because he was supposed to join. And then, of course, we have guest of honor, 3 guests of honor, Dr. Durgadas, Asrana, Vidyatobi, and Dr. Kasturi. So we will have their words as well. And then Dr. Rajendra Singh Pardesi from our Amogs side.
Yes, ma'am. I would now request Dr. Rajendra Singh Pardesi. Sir, your words of wisdom.
Good evening, everybody. Respected Chief Guest, Dr. Dr. Basavaraj Sajjan, guest of honors, Dr. Kasturi Dominath, Dr. Durgadas, Dr. Vidya Thubbi, and our dynamic president of Amog, Dr. Kiran Kurtakoti, and seniors Dr. Nagaraj, Dr. Bharti Rajsekhar, Dr. Rajeshri Paladi, Dr. Suman Gaddi, and friends. I wish to congratulate Dr. Sneha Boyar, our active chairperson of Emergency Obstetric Committee of Amogs, for organizing this academic feast on topics venous thromboembolism in pregnancy and cholestasis in pregnancy with the eminent faculties like Dr. Megha Kamlapurkar, Dr. Sneha Boyar, and chairpersons Dr. Vidya Murthy, Dr. Sunanda, Dr. Shobha Shiragur, Dr. Shashikala Gauri, Dr. Sonia Mandappa, Dr. Anita Konin. I think this is going to be a great event. I wish every success to Dr. Sneha Boyar for her future endeavor in Foxy as she is contesting for the post of Vice President in these forthcoming elections. So, thank you, Dr. Bharti Rajsekhar, for your words about Dr. Sneha. I wish every success to Dr. Bharti Rajsekhar also, as she is contesting for the post of Chairperson Perinatology Committee, Foxy. I wish every success to Dr. Bharti Rajsekhar. We are with you, Dr. Bharti. And same to Dr. Kasturi Dominat also, as she is contesting for the post of Chairperson of Quiz Committee. We are always with you. I don't want to be in between you and scientific content. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. Thank you so much for your blessings and support always.
Thank you so much, sir. Sir, of course, we are knowing that July 28th is World Hepatitis Day. With Amogs having the same intentions as the Ksoga office bearers have been a strong pillar and support to whichever concept we are coined till date. So in this line, we also have our President-elect, Dr. Durgadas Sasrana, sir, and we also would like to hear from sir.
Good evening, everybody. Respected Dr.
Good
Kiran
evening, sir.
Kurtakoti sir, Dr. Bipin Pandit sir, Dr. Rajendra Pardesi sir, and Dr. Madhuri Mehendale madam, and my own family of Ksoga. It is other day while Sonia called me up and told this is the last session before the elections of Sneha Bhuya. Madam, we have seen you for the past nearly 2 years, in fact. And we have seen, I have invited you to Tumkur also. We have seen your zeal of working. We wish people like you, Dr. Bharti Rajsekhar and Kasturi, we want to be in Foxy. It is for the betterment of Foxy, people like you should be there, to be there in the seat. And of course, our Vidya Topi madam is already there in the chair. So, I wish all the best from my heart. All the three of you should come out with flying colors. Second thing about today's topic, as it's rightly told, venous thromboembolism, and a very good speaker, Megha Kamala. This is a very important topic, and it is very rarely addressed. So many times we neglect this topic as the obesity is increasing and lifestyle is changing. The risk of thromboembolism is increasing, and very aptly chosen topic, and more than that, very aptly chosen speaker, because I know her personally. She speaks to the point. And coming to cholestasis of pregnancy, very oftenly we are seeing these cases now, and none other than Sneha Buyar is talking. I thank the whole organizers for giving me this opportunity, and once again my special wishes to Dr. Sneha, Dr. Bharati, and Kasturi. All the best. Thank you.
Thank you so much. Thank you. Thank you, Durgadas sir. I think we can have, do we have, yes, Dr. Vidya and Dr. Kasturi.
Sonia, ma'am.
Ma'am.
Yeah. I request you to please introduce Vidya ma'am.
Okay. Madam is President of Ksoga 2023, State Advisory PCP NDT Board Karnataka, Chairperson for Food, Drugs and Medico-Surgical Equipment Committee FOXI 2018-2020, Best Committee FOXI Award Dr. Mehrudara Hansotia 2020, ICOG Governing Council Member 2023 to 25, FOXI Champion Award 2019, National Corresponding Editor of JOGI, Organizing Chairperson Ksoga 2016, President Bijapur OBGYN Society 2019 and Secretary 2009 and Secretary 2007. Publications in various books and contribution to FOXI Focus, speaker at national and international conferences, papers at national and international conferences, organized various CME workshops and awareness programs, advisory faculty of boards of RGHS, postgraduate and undergraduate teacher for 30 years. Dr. Vidya ma'am. Hello.
I think both of them are busy. I can see Vidya. Yeah.
Madam is connected. Yes, Madam. Vidya
Yeah,
ma'am.
yeah. Yes. It is always a pleasure whenever I get connected with Dr. Sneha Buyar's any series of Amogs emergency web series, and she connects with the very innovative topics, and definitely it always have good carry home messages and very practical points whenever she discusses any panel or any topic. So I wish this webinar to be success, and I take this opportunity again to she is contesting for the Vice President West Zone, and there are 2 votes. Please vote, first vote for Dr. Sneha Buyar. And also, I take this opportunity to say few words about my Ksoga also. Ksoga is always connected with the people, and I must congratulate Dr. Sonia Mandappa as well as Dr. Anita. They always take a very keen interest in arranging these webinars, communicating with chairpersons. So today they have chosen very offbeat, very means they have connected to the other parts of our Ksoga societies, and I congratulate those chairperson, those who have joined this time. And let us view this webinar very seriously and enjoy the academics. Thank you very much.
Thank you,
And I
madam.
thank Dr. Rajendra Singh Pardesi for congratulating me. Of course, with all the supports, I think we will do better, and we will put our great work forth in 2026, of course. Thank you. We are doing now also, but definitely major work we will be doing with the support of Dr. Pardesi as well as Maharashtra. Maharashtra is always support for me, and as Ksoga is. Thank you very much.
Thank you so much, Dr. Vidya.
And Dr. Bharti had joined, so I did not see her. So our president has also joined, and she is also contesting for the perinatology committee. So I wish her also best. Okay, thank you very much.
Thank you. I was here when you were in the other web.
Okay, okay. Thank you.
Dr. Kasturi also.
Yeah, I was in, sir, just now. Yes. We recognize the presence of our beloved past president, Dr. Kasturi Donimat. See, her smile itself says it all. Madam, over to you for a few words.
Yes, yes. Good evening, everyone. Namaste. Ellargu namaskara. So this actually I was in one more webinar, so it was little late in joining here. Especially I thank Dr. Sneha and Dr. Rajendra Singh Pardesi and whole Amogs for giving me this opportunity. It's very pleasant to be in a platform where both Ksoga and Amogs is there. You know, it's like twin sisters, Ksoga and Amogs. And the Amogs has done lots of activities along with Ksoga, so many academic activities, and they have really enhanced the knowledge and so much of skill transfer between both the societies. So thanks to you, sir, Pardesi sir, for this initiative, and thank you very much, Dr. Sneha, for giving me this opportunity. And I also thank Dr. Kiran Kurti sir, Dr. Bipin Pandit, Dr. Madhuri, everyone for taking up all this, so many academic activities. And today we have very interesting talk on venous thromboembolism in pregnancy by none other than Dr. Megha, a very close friend of mine, Megha. And to chair this session, we have Dr. Vidya, who is actually my classmate and my good friend, and Dr. Sunanda. So this, and I especially thank all our Ksoga members, our chief patron, Dr. M.J. Remat sir, Dr. Nagaraj sir, and our present president, very dynamic president, ever smiling Dr. Bharti, and Dr. Vidya, my very, very close friend, always with me. We are like twin sisters. So thank you, Vidya. And Dr. Rajeshwari Paladi, our secretary, and our incoming president, Dr. Durga Das, again, very, very energetic, enthusiastic personality, and Dr. Suman is listening. So it's Amogs and Ksoga are doing excellent work. So thanks for this. And on this platform, I seek support and blessings for Dr. Sneha as Vice President, and from Karnataka for Chairperson, Dr. Bharti Rajshekar, and myself from Karnataka. So we seek wholehearted support from whole Amogs and Ksoga. Yes. Thank you,
Thank
sir,
you.
for this opportunity. Yeah.
Thank you very much, madam. And we also wish all the best for all the contestants from in Karnataka and outside Karnataka too. With this, I think we move ahead with the scientific sessions. Madam Dr. Sneha, with your permission.
Yes, definitely. I
to
would
the
like to
scientific
just
session.
thank all the dignitaries and of course the office bearers of both Amogs as well as Ksoga. I think Dr. Kiran Kurtakoti was busy and he could not join. Dr. Rajendra Singh Pardesi, always there to bless us and support us. So thank you so much, sir. And of course, Dr. Hiremat sir, he talked to me personally. Today, his sister is admitted and facing some health issue. So Dr. Basavaraj is also traveling to Bangalore. So both of them conveyed me their blessings. I'm very happy and thankful to Ksoga. Of course, the president of Ksoga, our dear friend Dr. Bharti, best wishes to you, and Dr. Kasturi, a very I would say best of luck to you. I just hope all of you come up with flying colors, and thank you once again to the entire team of Ksoga as well as Amogs. Of course, Dr. Durga Das Asrana, the incoming president of Ksoga, always very enthusiastic, very positive, vibrant personality. We are so thankful to you for your presence as well as your precious words. Thank you so much, all of you, all the faculties and chairperson. We are very happy to have you. And without much ado, I think we should go ahead with the academic session. Over to you, Dr. Sonia. Thank you so much.
Thank you very much, ma'am. And here's the long wait of, we don't want to be obstructed anywhere. Either it is ourselves personally or the blood vessel by a form of a clot. For that, we are today here to listen to Dr. Megha on a topic which is very important for we clinicians, we obstetricians. And Madam's talk will be actually chaired by Dr. Vidya Vasudev Murthy and Dr. Sunanda. I want Dr. Anita and I request you to introduce our chairpersons.
Thank you, ma'am. The chairperson of today's first session, that is thromboembolism in pregnancy by Dr. Megha Kamlapurkar, ma'am. Dr. Vidya Vasudev Murthy, ma'am. She is working at Vidya Maternity Hospital, President Haveri Obstetrics and Gynec Society for the year 2024, Chairman Women's Doctors Wing IMA Ranebunner presently. She's passed out from KMC Hubli, and she's completed her graduation from CPS Mumbai. She's delivered lectures at various CMEs programs from till date. She served as IMA President Ranebunner from 2015 to 2018, organized various health camps, including pap smear and breast cancer screening camps for women. Dr. Sunanda N. Madam, Associate Professor and Unit Chief, Department of OBG, Mysore Medical College and Research Institute, President Amogs 2024-25, Organizing Co-Chairperson, FOXI South Zonal Conference with UR 2024, MBBS from MMC Mysore and MD OBG from BMC Bangalore. More than 15 years of undergraduate and postgraduate teaching. Presented papers and lectures in state and national conferences. Treasurer, Mogs for the year 2013. Secretary for the Mogs 2014. Joint Secretary, Ksoga 2015 conference. Vice President, Mogs 2023 to 2024. Several scientific publications in national and international journal. I request the chairperson to please introduce Dr. Megha Kamlapur ma'am, the speaker on thromboembolism for today's webinar.
Very good evening to all of you. To start with the scientific session, I think the first topic will be on thromboembolism in pregnancy, and the speaker for the this topic is Dr. Megha Kamlapurkar, and she's a director of the Devata Hospital, Gulbarga, Karnataka, and she has her obstetric practice since the past 20 years, and she's a practicing fetal medicine in the high-risk pregnancies. She has been a faculty in the state and the national levels and delivered many talks on fetal ultrasound, and she has presented many papers and posters. Recently presented a paper in the 18th World Congress of Fetal Medicine Foundation in Spain in 2019. She Fetal Medicine Foundation UK certified in NT and anomaly scan. Our hospital is Foxy recognized ultrasound training center for the OBGYNs, and she's a vocalist in Hindustani classic music and has passed BA level Sangeet Vishrant, and the first center in Kalburgi, Bidar, Raichur areas to offer the invasive and genetic testing. And as we all know today, the thromboembolism is one of the leading cause, more so in the developing countries compared to developed countries, with the prevalence being 0.5 to 2.2 per thousand deliveries. And when we talk about the pregnancy is one of the important risk factor. It increases the risk of thromboembolism, and the risk increases even more in the postnatal period up to 12 weeks of gestation. And Madam will be delivering her lecture on this important topic, which is which in a few, these days we are coming more with more diagnosis of those women who are coming with this preeclampsia leading to thromboembolism, and also sometimes the APLA syndrome where the women are presenting with recurrent pregnancy loss. Over to you, Madam, for your oration.
Thank you. Can I share my screen?
Yes, you can share, Dr. Megha.
Yes, ma'am. You can make it full screen, I think.
Is it seen?
Yeah.
Okay.
Yes, madam.
Respected Dr. Hiremat sir, Dr. Basaraj Sajjan sir, Dr. Bharti Rashekar ma'am, President Ksoga, Dr. Kiran Kurti sir, President Amogs, Dr. Rajendra Singh Pardesi sir, past President Amogs, Dr. Bipin Pandit sir, Dr. Madhuri Mendere ma'am, Dr. Vidya Thube madam, Dr. Kasturi madam, Dr. Basavaraj Sajjan sir, Dr. Durga Das sir, my friend Dr. Rajeshri, Dr. Suman, and my young friends Dr. Anita and Dr. Sonia and Dr. Sneha Bhoyar madam for giving me this an opportunity. As was mentioned by Bharti madam that it's a Maharashtra and Karnataka, it's like a twin. So for me, it's like my Janma Bhumi, Maharashtra, and Karma Bhumi as Karnataka. And I'm very happy to talk on today's topic as venous thromboembolism in pregnancy. So venous thromboembolism in pregnancy as such consists of deep vein thrombosis and pulmonary embolism, which are the major factors for maternal mortality. And this data I have taken from American Society of Hematology, where it says that venous thromboembolism is the leading cause of morbidity and mortality in pregnancy. And venous thromboembolism complicates about 1.2 patients in 1,000 deliveries. And during pregnancy, the risk of venous thromboembolism is fivefold compared to non-pregnant state, and it becomes 30 to 60 times more during postpartum period. The increased risk persists until 12 weeks postpartum, with the greatest risk, which is in first 6 weeks after delivery. The diagnosis, prevention, and treatment of venous thromboembolism in pregnancy must consider both fetal and maternal well-being. So why is this important? For that, we need to understand certain facts that the risk of thromboembolism is 6 to 22 times higher in women during pregnancy and puerperium than in non-pregnant women, and the incidence we have seen. The risk is equal almost in antepartum and puerperium. The deep vein thrombosis is more common during antepartum period and pulmonary embolism in postpartum period. The frequency of frequency in puerperium has decreased due to early ambulation techniques, and however, the diagnosis is increased due to newer modalities. Pulmonary embolism is still the leading cause of maternal deaths. The risk factors associated with increased risk of thromboembolism we need to take into consideration, because all these women are at the risk, and we need to just stratify the risk during the first visit in antenatal OPDs. So we need to know what are the risk factors like cesarean section after delivery, diabetes mellitus, hemorrhage, anemia, hyperemesis, immobility due to prolonged bed rest, or multifetal gestation, multiparity, preeclampsia, and puerperal infection. The other general factors are age, IVF pregnancies, cancer, connective tissue disorders, dehydration, immobility, infection, myeloproliferative disorders, obesity, nephrotic syndrome, OCPILS, sickle cell disease, thrombophilia disorders, maybe acquired or congenital, smoking, and orthopedic surgeries. We come across many obese patients nowadays in our OPDs, and when we talk about the risk of having this to them, they are not concerned. They don't care at all if we tell them that this risk of thromboembolism for you will be more, and you have to just be vigilant about your weight gain during pregnancy. But I feel they are least bothered about these complications. The history of venous thromboembolism in first degree relative is very important. We need to take the history in details at the time of registration. With the history of inherited thrombophilias, we have to investigate for antiphospholipid syndrome and inherited thrombophilias as well. Just a minute, I'll just start my. Just a minute. I'm not able to slide. I'm not able to move my pointer. Is my screen
could you help, madam?
Yeah. I'm not able to take the pointer. So, my screen is seen.
No, but then it is not full screen.
Minimize, madam. It is
Yeah.
minimized. Sahiti, are you there?
I'm not able to make it as a
full screen. You can make it a slideshow.
No, I'm not getting the pointer.
Both bring me some lunch.
Shall I close and then see?
Yeah, you can close it. You can search for the pointer, and then you reshare again. That you can do.
I'm very sorry for this technical glitch. You see?
No, otherwise you can. We can see your screen, but that is minimized, and you can make it full screen and continue with the presentation.
Actually, I'm not getting the pointer to make it as a full screen.
Now it's gone, ma'am. The screen is gone now.
Now you reshare. That is what I told her. And the slideshow, yeah, perfect.
Okay.
But it is not happening.
Yeah, from current slide.
But I'm not able to use
right.
It's okay.
Yes.
So we need to take into consideration.
What happened?
She's become mute.
No.
I-
Dr. Megha?
Hmm.
Oh. We can see her screen. Hello? Huh, Megha?
Hmm.
Hello, Megha?
Okay. Madam, she's actually got disconnected.
Oh, okay. She joining again or
Yes,
how?
yes,
Should
she's
I
joining.
do- Okay.
She's joining again. Meanwhile, you would like to want to present, ma'am, or we'll wait for madam?
Yeah, but what is she saying? Immediately, is
Hello?
there any network issue or how? I'm ready with the presentation.
Okay. Okay, done, ma'am. Yeah, she could join.
Okay, good.
Yes, madam, you can share from the beginning.
Yes.
No problem, ma'am, you relax.
Is it okay?
Yes,
Yeah,
yes.
yeah, it
Relax,
is
ma'am.
perfect.
Not to
Megha,
worry.
relax and go ahead, please.
No problem, ma'am, relax.
Connected. Okay. Is it going? So the major components of hemostasis, when we consider the vasoconstriction as soon as there is a damage to the endothelial surface, and that is followed by platelet activation, that is called as a primary hemostasis. Am I audible? And
Yes, madam.
see?
Yes, yes, perfect. Megha, audible as well as your slides are visible. No worries. Please go ahead.
I cannot hear. I'm not able to hear, madam. Sneha madam, you are mute.
No,
Ma'am,
no, I did talk
And
to
then
you.
coagulation cascade
No problem.
with antithrombotic mechanism, including fibrinolysis, will be secondary hemostasis. And we need to consider the major components for hemostasis. As soon as there is a vessel injury, as we can see here, there is release there will be release of tissue factor and collagen, which leads to platelet activation. And first, it happens as a vasoconstriction to prevent the blood loss. Then coagulation cascade sets in, and then there is a formation of platelet flood with the activation of platelets, which comes under the primary hemostasis. Whereas coagulation cascade comes in the play, the thrombin acts on fibrinogen and fibrin strands are formed, thereby forming a blood clot, which comes in secondary hemostasis. Because this figure is very important, we have to understand this for understanding how is the management done for venous thromboembolism. And then this blood clot later on, in presence of plasmin and plasminogens, undergoes fibrinolysis and clot degradation occurs. Again, this image is very beautiful. And then this fibrin clot undergoes the fractionation, and then we get this FDPs in the blood, which we use for the investigation purpose. So there is a hemostatic balance between the procoagulative factors and anticoagulative factors. There is coagulation cascade and fibrinolysis, and this balance is when it is disturbed, then we get these disorders, and this pregnancy is a high risk factor for this. The normal physiology, what happens in the normal, why don't we get thrombus in normal vessels? It is because endothelial cells normally inhibit the thrombus formation through multiple mechanisms like secretion of prostacyclins by these endothelial cells, PGI2, or secretion of nitrous NO, and which vasodilates and inhibits platelet activation and aggregation, expression of heparin like sulfates, and it activates the antithrombin, and which prevents the normal thrombosis in the normal vessels in normal conditions. So what are the hemodynamic changes that occur in pregnancy? There is increased intravascular volume, as we all know. There is decreased peripheral resistance, decreased venous pressure, and increased venous capacitance. There is platelet function which is altered, and that causes more and more activation of platelet aggregation and formation of thrombosis. There is enhanced platelet aggregation which leads to increase in the risk of thrombosis, which combined with reduction in fibrinolytic activity results in more and more clot formations which are more resistant to the degradation. So this is a good image which can tell us that what are the physiological hypercoagulatory changes which occur along with the venous stasis and the endothelial tremor which occurs during delivery. So normally the coagulation of fibrinolytic system aim during pregnancy is to reduce the intrapartum blood loss, but at the same time inadvertently it increases the risk of thromboembolism. And we here can see what are the factors which are increased and what are the factors which are decreased during pregnancy. So the procoagulants like thrombin, they are increased, and whereas the anticoagulant factors like protein C and S and antithrombin 3 are decreased in the pregnancy. So what is the pathophysiology? We all know, we have already studied in our pathology classes, that what is the pathophysiology of thrombosis? It is the virtuous triad which described as the stasis, vessel wall trauma, and hypercoagulability. So stasis during pregnancy is very common because of the vena cava compression, which leads to platelet aggregation, platelet binding in the venous walls. Whereas the vessel trauma, which occurs during delivery, is also one of the contributing factors for increasing the risk of thromboembolism after puerperium. And hypercoagulability, which occurs due to increased synthesis of coagulation factors during pregnancy. So this is a very good figure to understand, very easy to understand, and equally easy to forget, very easily forgotten. Wherever we see and understand and we feel, oh, I have learned coagulation process and I will not forget. But in another week, we just forget. So whenever we want to study, again, we just refer this figure. So this is always, there is a balance between bleeding and thrombosis, which is maintained by this coagulation cascade. So this coagulation cascade, in short, I'll go into that. So factor 12 starts with factor 12, reaches up to 9 factor, with 8th and 9th factor, with tissue plasminogen factors, it activates the factor 10 along with factor 5, which causes conversion of prothrombin to thrombin, and antithrombin is converted to thrombin, and thrombin again converts fibrinogen to fibrin, thereby allowing the platelet plug formation and blood clot. The proteins come in this way. Protein C will get activated to activated protein C, and then to protein S, and then this protein C pathway, it will come in the formation of the blood clot. Whereas the fibrinolysis, the plasminogen will activate this plasmin and then will help for the release of the fibrous clots. So what happens during pregnancy? There is the factors like factor 7, 8, 10, and von Willebrand factor, they get increased in levels. Fibrinogen also increases, reaching to twofold increase in than the non-pregnant state. Whereas the antithrombin and protein C, there is not much change which is seen during pregnancy, and protein C activity is reduced. So plasminogen, antiplasmin, they increase about 2 folds over the non-pregnant states. The plasminogen activator inhibitor type 1 and 2 plasminogen, they are increased, and there is plasminogen activator is reduced, and therefore, and venous flow velocity, what we see during pregnancy, is decreased, and all this predisposes to venous thromboembolism during pregnancies. So there are several important regulative proteins which act as inhibitors at strategic sites in coagulation cascades, like we see protein S and protein C, which control the thrombin formation, conversion of prothrombin to thrombin, and thus they control the formation of clot formations. So inherited and acquired deficiencies of these inhibitory proteins collectively is referred to as thrombophilias, and that can lead to hypercoagulable state and recurrent venous thromboembolism. They account for more than half of all thromboembolic events that occur during pregnancies. So when we come to thrombophilias, we know that the antithrombin 3 deficiency, protein C deficiency, and protein S deficiency are considered as high-risk thrombophilias. Why we need to understand that? When we'll come to know that in future slides. Second is moderately risk thrombophilias. They are like factor V Leiden deficiency or prothrombin gene mutation or factor VIII deficiency, whereas the low risk thrombophilias encompass factor 11 and factor 9 and hyperhomocysteinemias. These thrombophilias, they are managed as per their severity. What are the factors which modify their risk during pregnancy? It depends upon the zygosity of the mutation in case of the inherited thrombophilias. Or is there any prior risk, history of thromboembolism, or is there any history of personal history of venous thromboembolism event in the life of a woman? So antithrombin 3 deficiency, I'll not go in the details of this. These are the thrombophilias which we need to consider, like in protein S deficiency also, and other factors, and homocysteinemia. So all these testing can be done during pregnancy. And is this testing reliable during acute thrombosis also? Yeah. Every column says that, yeah, this is possible. And is testing reliable when the patient is on anticoagulation? Yes, we can do these tests. These are available nowadays, and we can get these patients tested for that. The important thrombophilia is the antiphospholipid antibody syndrome, where we need to consider anticardiolipin and leukocoagulant, anticoagulant antibodies were mostly found to be associated with the thromboembolic events apart from recurrent pregnancy loss. So a 2:1 ratio of venous to arterial thrombosis characterizes the APS, and thrombosis here has the risk of recurrence, and that is why we need to investigate these women. Venous thromboembolism, specifically deep vein thrombosis of the leg, is most common manifestation and recurrence of APS. Superficial thrombophlebitis, as we see these patients in OPD with clinical features of swelling of the legs, redness of the involved limb, erythema, tenderness, there is warmth and palpable cord around the course of the superficial veins involved. What about the deep vein thrombosis? The 50% of these patients, they are asymptomatic, where deep vein thrombosis is more common in left than on the right side, because left iliac vein is compressed by the right iliac artery. There is a pain in the calf. This patient will come with a dorsiflexion, which is elicited as a Hoffman sign. There will be dull leg, tingling, tightness, especially while walking. So when we see these patients, we can see that the rule of three. So when the patient is patient is bedridden for more than 3 days in 1 month, or if she has undergone history in last 3 months, history of surgery in last 3 months, or if she has calf muscle swelling, which counts more, if it is more than 3 centimeters calf enlargement on one side, then this patient is diagnosed as a case of deep vein thrombosis. Why we need to worry about deep vein thrombosis? Because if it causes the distal deep vein thrombosis, or if it causes the proximal, where it involves iliofemoral vein, it can cause blue limb, it can increase the venous congestion, or if the vein is enlarged, it will compress the adjacent artery, and the whole limb distal to that will be white limb because of the ischemia. Other problem, what we are worried about deep vein thrombosis, is the pulmonary embolism, which is a very deadly event, where the blood supply to the lung, which comes from pulmonary artery, is reduced, and completely there will be no loss to the no blood supply to the lungs, and there will be no there will be no supply to the left side of the heart, and eventually the systemic supply also will come down, and the patient can go in shock. So what are the types of DVT that we need to understand? It is the IVC, followed by iliac veins, femoral vein, popliteal vein, and these are the peroneal veins. So when DVT occurs in this iliac part, it is called iliac DVT, or femoral DVT, popliteal, or peroneal DVT. We need to understand this because the DVT up to popliteal vein is called as the proximal DVT, whereas beyond that we call it as a peroneal DVT. That is helpful for managing these patients. So when we know the DVC, when we diagnose, how can we diagnose, and why it is important? Because these cases are predisposing factors for pulmonary embolism. In non-pregnant women, DVT originates in calves and progresses proximally. In pregnancy, whereas it originates from the proximal veins of lower limbs, about 79% from the iliofemoral veins. And the Wells criteria, which are described or used for the diagnosis of DVT, cannot be applied in pregnancy, neither the Geneva score. So what is the clinical prediction? How can we predict that? It is with the rule of left rule by Chen et al., where we consider the left lower extremity symptoms, the difference in circumference of the calf more than 2 centimeters, and if it presents in first trimester. It is useful if ultrasound is equivocal and D-dimer utilities, and we do D-dimeresis for this, but the utility is limited due to physiological rise in pregnancy. So we need to consider this flow chart, how we can use this. If we suspect the DVT, then we can do ultrasound, and if it is positive, we can manage the patients accordingly with the low molecular weight heparin or oral anticoagulants, depending. If this compression ultrasound is normal and suspected iliac vein thrombosis is seen, we can offer them the MR venography or CT venography. But if it is not available, as we see in most of our cases, most of our situations, we can offer them compression ultrasound again after 3 to 7 days. If the ultrasound is equivocal, where we can just get their D-dimer test on day 3 and then day 7. If it is more than 500, then it is positive, then we can manage that patient accordingly. And if it is negative, that means if it is less than 500, then we are ruling out DVT or pulmonary embolism. But if the ultrasound is normal and still we suspect pulmonary embolism as per the patient's history, then we have to manage the patient as the case of pulmonary embolism. What are the treatment options available? As we are showing, why we need to classify this DVT as proximal or distal DVT, that depends upon the that is needed for the treatment options. When we see that the DVC is proximal and it is, to the extent that the whole limb has become blue, that is phlegmasia, ceruleia, dolens, then we advise actually the thrombectomy. Whereas proximal DVT, we can give them anticoagulants or inferior vena cava filters if available. And in distal DVT cases, we can anticoagulate them or observe with the repeat ultrasound. The important note here is that treat underlying cause of DVT, or otherwise we'll be losing, and the patient may come again with a recurrence in pregnancy. So pulmonary embolism, how we need to know the pathophysiology of pulmonary embolism. Pulmonary artery is at the fault here. Whatever venous supply is coming to the left side of the heart, the pulmonary artery arises from the right ventricle and goes to, and then branches out. So here the pulmonary embolism will be at the origin of the pulmonary artery. So there will not be any blood supply to the lungs. So what will happen? That is possible, and we can have this mnemonic. Remember this as a fatal. Fate is, it can present as fat embolism or air embolism or thrombosis from DVT or amniotic fluid embolism, or then less common causes like septic embolisms. So what are the classical presentation of these symptoms? Obviously, when there is less blood supply to the lungs, the patient is going to have dyspnea, chest pain, hemoptysis, hypoxemia, and again the cardiac symptoms will come set in, and these are like the tachycardia. So what happens here, because the disease alveolus is, there is fluid in the alveoli, there is no gas exchange which is occurring here. So that will lead to hypoxemia, ventilation perfusion mismatch, and there will be shunting of the blood, and the patient will have respiratory failure. And again, because there is no blood supply, the blood being oxygenated in the lungs, the left side of the heart, left atrium and left ventricle will not get enough blood, and the systemic blood also will cut down, and the patient will get reduced cardiac output followed by the shock. So different symptoms and how we need to suspect them. Various pulmonary embolism rule out criteria are available. So Year's algorithm, which is very important, that includes 3 criteria. That includes clinical signs of DVT. Then second is the presence of hemoptysis and pulmonary embolism as the most clinical diagnosis. We have to use that. Since pulmonary embolism originates primarily from underlying DVT, compression ultrasound is the first investigation of choice in these patients. As per RCOG, chest X-ray is the first investigation, but in most of these cases, the chest X-ray can be normal. So various various scores are available. That's I'll not go into the details, but we can use these scores, and then as per the score, we can give the treatment to these patients. So how to differentiate now? This is very specific. We need to suspect amniotic fluid embolism, and we need to differentiate how we can differentiate this from the pulmonary embolism. In amniotic fluid embolism, there will not be any predisposing factors for thromboembolia except pregnancy, and then amniotic fluid embolism is seen only during labor. Invariably, the patients will present as DIC. It never occurs with intact membrane, and presence of fetal cells in the maternal circulation is must to diagnose this as an amniotic fluid embolism. Whereas pulmonary embolisms, predisposing factors are present. We can other predisposing factors are seen. We can see that can be seen in antenatal period, intranatal, or in postpartum period. DIC need not be there for pulmonary embolism to be seen or diagnosed as. It's not related to it, and there is absence of fetal cells in the maternal circulation, which will help. So there is a very good flow chart that will help us to manage the DVT and pulmonary embolism. We can just take this picture, and because of the paucity of time, I'll just skip this. But this is very important to manage. So how is this initial anticoagulant treatment for venous thromboembolism in pregnancy? In clinically suspected DVT or pre-pulmonary embolism, treatment with low molecular weight heparin should be commenced immediately. We should not wait until the diagnosis. We get the and unless it is strongly contraindicated. So low molecular weight heparin should be given in doses titrated against the woman's booking or early and pre-pregnancy weight as per her weight at the time of the diagnosis of pregnancy. Should the blood test be performed to monitor heparin therapy in pregnancy? So routine measurement of antigen factor activity is not recommended except in women at extremes of body weight, that is less than 50 or more than 90. Most of the women we are nowadays seeing are more than 100 kgs, or the patients who have renal impairment, or there is a history of recurrent venous thromboembolism. For them, we can monitor this with this test. So routine platelet count monitoring is not needed, and obstetric patients who are post-operative and receiving unfractionated heparin should have platelet count monitoring performed every 2 to 3 days from day 4th to 14th until heparin is stopped. So these are the various doses available as per the booking weight in the early pregnancy, and we can just follow them. And then when the weight is more than 125 kg or more than 110 kg, we need to take the help, and we need to have multidisciplinary approach to monitor the dose of this heparin for these patients. So same is as like heparin, the doses of a deltaparin are also dependent upon the weight, and we can refer this chart for having this dose assigned to our respective patients. How should we manage the life-threatening pulmonary embolism? Definitely, we need to have a multidisciplinary approach, including senior physicians, obstetricians, radiologists, and ICU persons, emergency medicine persons. Women should be managed on an individual basis. Of course, tailor-made approach needs to be there. Intravenous unfractionated heparin, thrombolytic therapy, or thrombectomy and surgical embolectomy can be offered. Then intravenous unfractionated heparin is preferred. There is urgent portable echo and CTPA, CT pulmonary artery. We need to have this facility within 1 hour of presentation. If massive pulmonary embolism is confirmed, or in extreme circumstances, prior to confirmation, immediate thrombolysis should be considered. So intravenous unfractionated heparin is the preferred initial treatment in the massive pulmonary embolism. Loading dose can be 80 units per kg, followed by a continuous intravenous infusion of 18 units per kg per hour. If a patient has received thrombolysis, a loading dose of heparin should be omitted and an infusion can be started at 18 units per kg per hour. So acute phase treatment can be thrombolytic therapy or streptokinase or TPA, but it cannot be recommended in pregnancy except in life-saving procedures like shock patient with massive pulmonary embolism or iliofemoral venous thrombosis. Anticoagulants like unfractionated heparin can be started IV infusion for 3 to 7 days. Monitoring has to be done, and fractionated or low molecular weight heparin can be substituted, and surgery as per the multidisciplinary approach can be decided. So adjustments in the infusion rates of unfractionated heparin according to APTT, what is the level of the APTT, we need to investigate and then change the dose and adjust the dose with our multidisciplinary approach. The additional therapies can be in the initial management of DVT, can be like limb elevation, graduated elastic compression stockings, and mobilization, which is very important, and the temporary inferior vena cava filters in postpartum patients with iliac venous thromboembolism and proven DVT, and who have recurrent pulmonary episodes despite adequate anticoagulation doses. We can just think of this inferior vena cava filters. So maintenance treatment for venous thromboembolism can be treatment with therapeutic doses of low molecular weight heparin should be employed during pregnancy and for at least 6 weeks postpartum, and at least 3 months of treatment has been given in total. The outpatient follow-up clinical assessment and advice with monitoring of blood platelets and peak anti-10 levels if appropriate or when indicated, as we had discussed before. So role of vitamin K antagonist. Because of their adverse effects on the fetus, vitamin K antagonists such as warfarin. We know that warfarin causes lot of musculoskeletal defect and facial defects in the baby. That is called warfarin embryopathy. So it should not be used in antenatal venous thromboembolism treatment. Newer anticoagulants are available and we can just use them. Anticoagulant therapy during labor and delivery, what we need to consider when venous thromboembolism occurs in the late pregnancy, consideration should be given to the use of intravenous unfractionated heparin, which is more easily manipulated. Caesarean section or induction of labor, low molecular weight heparin maintenance therapy should be discontinued 24 hours prior to the planned delivery. Regional anesthetist or analgesic techniques should not be undertaken until at least 24 hours after the last dose of therapeutic low molecular weight heparin, and it should not be given 4 hours after the use of spinal anesthesia. So we can, after cesarean, we can start after 6 hours or after epidural catheter has been removed, and epidural catheter should not be removed within 12 hours for most of the recent injection. So what is the care that we can take during cesarean section? All women who have had cesarean section should be considered for thromboprophylaxis with low molecular weight heparin for 10 days after delivery, and apart from those having an elective cesarean section who should be considered for thromboprophylaxis with low molecular weight heparin for 10 days after delivery if they have additional risk factors other than pregnancy and puerperal. So what is the surgical care? What we can take for these patients is we can use the drains for preventing the soakage of the wounds, the skin closure, better by interrupted sutures to allow the drainage of any hemorrhage collection. And what is the anticoagulant therapy should be employed in women who are at the high risk of hemorrhage. So any woman who is considered to be at high risk of hemorrhage and in whom continued heparin treatment is considered essential should be managed with intravenous unfractionated heparin until the risk factors for hemorrhage have been resolved. So in such cases, we can shift to unfractionated heparin. So postnatal anticoagulation, they should be offered. The choice is low molecular weight heparin or oral anticoagulants for postnatal therapy. After discussion, of course, with the patient about the need for regular blood tests, regular follow-up, monitoring of warfarin, particularly during first 10 days of the treatment. Postpartum warfarin should be avoided until at least 5th day and for longer in women who are at increased risk of postpartum hemorrhage. Women should be advised that neither heparin nor warfarin is a contraindication for breastfeeding, and they need not be worried about breastfeeding the baby. So postnatal clinical review is very important. Thrombophilia testing should be performed once anticoagulant therapy has been discontinued, only if it is considered that the results would influence the woman's future management. Otherwise, we can just postpone and offer them as per the indications. For how long it should be continued after delivery? Preferably for 6 weeks, and after 6 weeks or longer if the patient has other risk factors. So doses of prophylactic doses are as per the weight we have seen, enoxaparin, dalteparin, and other anticoagulants. So what are the contraindications when we can't use low molecular weight heparin? These are the known bleeding disorders like hemophilias or von Willebrand disease or acquired coagulopathy or active antenatal or postnatal bleeding. Women considered at increased risk of major hemorrhage like placenta previa, thrombocytopenia where platelet count is less than 75,000, or acute stroke in previous 4 weeks of pregnancy, severe renal disease, severe liver disease, uncontrolled hypertension. So these are the contraindications for use of low molecular weight heparin. This is one good risk assessment score. We can get it printed on a paper, attached in our file, ask our and train our staff to just get the risk of this patient when the patient is registered in our hospital, because it is going to give us the management plans. So this is a very good score. Score is given, and then we can though this is a transient, we can just use during the pregnancy for managing our patients. So risk assessment for venous thromboembolism in pregnancy: if the total score is more than 4 antenatally, thromboprophylaxis should be started from the first trimester. But if the score is 3 antenatally, thromboprophylaxis can be started from 28 weeks onwards. And if the total score is more than 2, postnatally, thromboprophylaxis for at least 10 days has to be offered. If admitted to the hospital antenatally, the patient is admitted with us, we need to consider thromboprophylaxis for them. And if there is prolonged admission more than 3 days or readmission to the hospital within the puerperium, we have to consider for the thromboprophylaxis. This is also a very good chart where we can see there is a, as per the risk of the patient and the risk factors and the thrombophilia, we can offer, we can stratify them as high risk or intermediate risk or low risk, and we can use this for the treatment. I'll not go in the details because of the time constraints. So thrombophilia associated with venous thromboembolism occurring because of the thrombophilia, which are hereditary or acquired, we need to have special management, and we need to involve the hematologist for this management. This American Society of Hematology has very good this patient information leaflet. We can use this and we can give this to our patients as whoever will be benefited. So thromboembolism prevention is better than cure, for as we say for all our diseases. I again thank Dr. Sneha Boya madam for giving me this opportunity to talk on a subject. I rarely talk on a subject which doesn't involve ultrasound at all. Here I could not include any ultrasound image, but I felt immensely helpful for me for managing our high-risk patients. I am really thankful to you, ma'am. Thank you so much. Thank you so much.
Thank you very much, madam. It was an excellent and an elaborate presentation. And I now request the chairpersons for their expert comments. Madam, Dr. Vidya and Dr. Sunanda.
Thank you, madam. Hello.
Ha, madam. Kelsata, madam.
Thank you, madam. It was very good information regarding VT. Day-to-day practice, we sometimes we come across with this usually postnatal thromboembolism. It's a good information. Thank you very much for giving such a good information.
Megha madam, it was a wonderful presentation. My few queries, like, are there any screening strategies for the women who are at risk for is thrombophilia, who are at risk for developing thrombophilia during pregnancy, thromboembolism? Any screening strategies?
Yes, we have Dr. Megha. Yes, Dr. Sonia.
Dr. Megha, ma'am. Madam is there.
Madam is there, yes.
But then you can't see her?
Yes, yes, ma'am.
Dr. Sunanda?
Yeah, madam.
Yeah, actually, screening test means if you want to see if they're at high risk, then you have to do APLA screening or thrombophilia screening and see whether they are prone for all this thromboembolism, especially if they are APLA positive and all. Then you'll have to be very careful that these patients can. Anyway, you would have put them on therapeutic dose of heparin throughout pregnancy. But if you are not put, because other day we had a case, she has not got investigated at all, and just 12 weeks, she has come with the thromboembolism. So even just early pregnancy also. Then we screened for APLA screening, then it came positive. So it's like this. So at least those highly suspicious cases, especially if we have a woman, if they give history that they have taken some OC pills or some hormones and they develop some thromboembolism, those cases you need to screen, and then preconceptionally only we need to start all these things.
Yes, madam.
I think we need to categorize the patient
Yeah.
right from the day one the pregnancy is confirmed. Categorize. I think every antenatal record should actually contain and then register as in block letters and high risk pregnancy. If there is a benefit of doubt, prophylaxis is the best method as well.
Yeah, I think Megha, that was a wonderful talk. I hope she's there listening to me. But it was an excellent and practical topic, I would say. If you remember, for KCOG, I was invited as I think Kasturi must be remembering.
Yeah.
I was the speaker for thromboprophylaxis during pregnancy, and there I have given the risk scoring, right? Okay, so without any major surgery or family history of the coagulopathy, so all these things were taken into consideration. So you have a score from 0 to 4, and depending upon that score, you have to decide whether you have to start thromboprophylaxis right from early pregnancy or 28 weeks onwards, whether you have to continue thromboprophylaxis throughout pregnancy, and after whether it is the last 10 days postpartum or 6 weeks postpartum. And there are some cases where you need to continue the thromboprophylaxis lifelong. So venous thromboembolism is the major risk where you have to continue the thromboprophylaxis for lifelong. So there, as per the risk scoring and the weight of the patient, even the dosages of the heparin and low molecular weight heparin, everything. I have the chart which was displayed actually. So I mean, practically she has covered almost everything. As somebody has asked, I think Dr. Vidya, that whether there is a screening test, if at all you feel that clinically there is a suspicion, right from history, you should have the high index of suspicion, and you yourself should triage this patient. And if you feel suspicious, you can subject her to the testing for I would say complete thrombophilia panel. If not, if you are just suspecting the APLA, you can go for the APLA testing. I think that should be all.
Thank you. Thank you, madam.
Madam, one more question. In case if it is not a high risk, but still, do you feel that per-operatively, a coagulation profile is a must for all cases, even though they are not a high risk? Are you practicing at your center this coagulation profile?
Yes, I can see Dr. Megha, and I think she'll be happy to answer that.
Madam, am I audible?
Yes, yes.
Yes, yes.
You are visible and audible, dear.
Because I was talking
now, I think you are logged in from 2 devices.
That's why it's echoing, ma'am.
You can put off the second device, that is the mobile. Yeah. Okay, so what she is asking you, did you get the question? Dr. Megha, you muted?
No.
I think you are muted from the laptop, and you are, yeah, it's a different device, right? Why don't you unmute yourself from the laptop and put off the mobile? Okay. I think, yeah.
Yes, ma'am. Laptop one, you have been unmuted.
Yeah, okay. And so Sonia, do we have any other question, or should we go ahead?
I think we'll go ahead, ma'am. We are actually with paucity of time. We move ahead, and the speaker of the day, the next session, is none other than by Dr. Sneha Boyar herself. Madam, we would like to hear from you a more versatile topic, and not many cases we see, but then the only ones when there is an itching history with pregnancy, that is when it will strike us whether it is cholestasis in pregnancy. So we want to know more about that with the evidences, ma'am. Thank you so much. Over to you.
Ma'am,
Yes.
please introduce the chairperson.
The chairpersons.
The chairperson for this session, Dr. Shobha Shirpur ma'am. She's Professor, Department of OBG BLD, Shri B.M. Patil Medical College Hospital and Research Center, Vijaypura. Consultant, R.K. Gudidini Hospital, Vijaypura. She's awarded second prize for poster presentation, Ksoga 2014 at Hubli. Worked as a part of WHO champion trial in association with Dr. Shiv Prasad Gowda sir, Professor Vijay JNMC Belgaum. Publications published 14 papers in various national and international journals. Citations in 260 since 2019. Special interest are high risk pregnancy. The other chairperson for the evening, Dr. Shashikala Gugri ma'am, consultant obstetrician and gynecologist in Hospete since 1901. Founder CEO of Gugri Hospital, Hospete. Field of interest infertility, and charter member, president of Vijayanagara Obstetrics and Gynecological Society, Vijayanagara. I request the chairpersons to please introduce today's second speaker, Dr. Sneha Bhuyar ma'am.
Do we have the chairpersons, Anita?
Yes, ma'am.
Shashikala ma'am.
Shashikala ma'am, Shobha
I will
ma'am.
introduce Dr. Sunanda N. Hello.
Ma'am, we have to
Sneha
introduce
ma'am.
Dr. Sneha ma'am.
Shashikala ma'am, Dr. Sneha's
Yeah.
introduction by yourself.
Yeah. Dr. Sunanda.
Dr. Sneha Boyar.
Okay. Shall I introduce Sneha Goyal?
Yes, ma'am.
Sneha Goyal, she got International MS Signature Award for Phenomenal Leadership in 2020, Asia CGC Award 2021, Dr. S.N. Malhotra Individual National Award for Outstanding Work in Rural Obstetrics in 2008, and Dr. Durusha Distinguished Community Service National Individual Award in 2022. Next, Individual Award, Champion of Foxy Award for 2 consecutive years, 2020 and 21, and Dira Award 22. Dr. Anandi Bhai Joshi State Award for Government of Maharashtra. Lokman Healthcare Excellence Award in 2020. 300 plus talks, 10 plus keynotes, and oration and moderated more than 100 panels, 30 plus chapters and articles in national publications. She is in a Foxy Breast Committee Chairperson, GCM ICOZ 21 and 22. She got National Adolescent Trainer, WHO, FPAI certified.
I think
National Peer Review of Jogi, Amogs Chairperson for Medical Disorders Committee in 2022-22, Amogs Chairperson Emergency Obstetrics 24-26, Mission Pink Health Committee Convener PCPNDT, SAF Suffolk Working Group Member of Breastfeeding, Founder Chapter, President Oaks 2007 and 8, Founder Clinical Secretary Oaks 2003, and Light Member Foxy, IMA, ISAR, IIAZE, IMS, and ISOPA. Thank you, Madam.
Thank you so much, and a very good evening to one and all. My respect and regards to all the seniors here, Thank you, Madam Shashikala Gugri, for that very generous and kind introduction. So without much ado, we would like to go ahead with the presentation, and I hope you can see my slides. And I'm just trying to make it full screen. So I think, yeah, Dr. Sonia? Dr. Sonia, I think Sonia and Anita, I hope you all can see the slides.
Yeah, it's seen,
Yes,
madam,
ma'am.
it's seen.
Yes. Okay. So thank you so much. And you know, this as Dr. Sonia said, you know, only when the patient gets itching, you think of the intrahepatic cholestasis of pregnancy. But I would say it is very common, and though in fact it sounds so simple, the itching during pregnancy, it has got profound impact on the maternal and fetal health as far as the pregnancy outcome is concerned. And that is why it is very important for all of us to know what is the etiopathogenesis, what are all the risk factors, and what are the presenting symptoms. How do you come to the differential diagnosis, and how do you come to the definitive diagnosis? Why should we know all this? Because it has got long-term consequences also, and what measures should be taken to improve the pregnancy outcome. So I would say this is actually the commonest gestational disorder, Dr. Sonia. This is actually the commonest gestational liver disorder. I have initially wished all of you a very happy World Hepatitis Day. And though hepatitis is not though hepatitis in fact is one of the causes for itching during pregnancy. So we are going to discuss this also in short. So we come back to the subject now, that this is one of the commonest gestational liver disorder, and that happens, you know, it actually presents itself during the second and the third trimester. Though the exact etiology is not known, the presentation is very, very very characteristic, that the patient presents to you as pruritus during pregnancy. And when you do her liver enzymes, you do her liver function test, you find that the transaminases, both ALT as well as ST, both of them are elevated, and you find that the serum bile concentration is elevated. Of course, we have to exclude the other causes of liver dysfunction and itching, and that is why confirmation of this diagnosis is very, very important. The overall incidence, if you look at this, 0.1 to 15.6%. So this is not very rare. Okay, this is quite a common presentation, and definitely we need to, give importance to this subject. So whenever you have such kind of, this impaired hepatobiliary, whenever you have these patients presenting with pruritus, you have the etiology mainly as environmental factors contributing to, by multiple factors like hormonal factors, like genetic predisposition. What is the exact position, that will come to it as a discussion later. But what is the basic pathophysiology? That there is an impaired hepatobiliary transport, and because of this, there is retention of the bile acids and the progesterone sulfates, which are actually result into the accumulation of this, or the elevated blood levels of these bile acids into the organs, resulting into cytotoxic and hormone-mediated organ dysfunction. So coming to the etiology or the contributory factor, as I have already said, genetic predisposition, the effect is strong, but it is the exact association is not clear still. You can have hepatitis B, hepatitis C, and cholelithiasis as one of the causes associated. Of course, multi-fetal gestations, elevated estrogen and progesterone levels, and stimulation in ART, that is quite closely associated. You have multifetal gestation, having almost 6 to 9% of the incidence, and the nutritional deficits of vitamin D and selenium is also thought to be contributory. Environmental factor, the role exact is not clear, but yes, if you have a history of cholestasis of pregnancy during last pregnancy, the risk of recurrence is almost 45 to 70%. What does the working group of obstetrics and prenatal medicine talk about? It says that pruritus, especially at night, starting in the palms and soles of the feet, and it is supposed to be the cardinal symptom of intrahepatic cholestasis of pregnancy. Of course, accompanying symptoms may include pain in upper abdomen, nausea, loss of appetite, sleep deprivation, and steatorrhea. And of course, because of steatorrhea, she lines up into malabsorption and various vitamins, especially the vitamin D. It can get less absorbed, and that is why she faces the other consequences as well. Up to 80% of these cases of intrahepatic cholestasis of pregnancy, they manifest after 38th week of gestation, and the time of manifestation is usually late second or early third trimester. So it can be diagnosed in a pregnant woman where you have pruritus, and when you do the total serum bile acid levels in a non-fasting state, that is at random, if it is more than 19 micromole per liter, then you can label this as having the intrahepatic cholestasis of pregnancy. A careful medical history, the obstetric history, and a complete thorough physical examination is required. If your gestational pruritus persists even with the total serum bile acid as normal, then of course you have to repeat this test every 1 to 2 weekly to assess the recheck or reassess the diagnosis of ICP. Australian data also reports ICP. There is a threefold increase in the risk of gestational diabetes mellitus and tenfold increase in the risk of preeclampsia. Now, though this is a busy slide, I would just tell you that what are the other causes of pruritus. So that is how we come to the differential diagnosis that pregnancy, you can have the atopy in pregnancy. That means pregnancy related pruritus, not because of the intrahepatic cholestasis of pregnancy. Polymer, where you have actually, this happens during the first trimester itself, and it can occur at any gestation. Usually the patient's skin is dry, eczematous, and she doesn't get all these typical flexures, but then wherever she has the folds, there she gets those lesions. Polymorphic eruption of pregnancy, there she gets a itchy rash, especially in the second and third trimester, and here you can get confused with the ICP. But papules, plaques, and often target lesions can happen here, which are not present in the ICP. Usually, pruritus, folliculitis of pregnancy, this also happens in third trimester. Acneiform eruptions, shoulders, you tell them that, this is quite common during pregnancy. You find you get the acne on the chest, on the back, and everywhere on the body. The rash improves with advancing gestation. Pemphigoid gestations or allergic drug eruptions, usually in the third trimester, and pruritus and rash at any gestation can present because of these drug allergies. Of course, you may get rarely blisters not responsive to the ICP therapy. And I have already talked about the maculopapular rash as it is. So other systemic diseases which can happen, so that you have to look for, especially if she has a pre-existing disorder. Pregnancy-related liver disorders, like right from early pregnancy, you can have hyperemesis gravidarum, where you have nausea, vomiting during first trimester, in fact, which worsens subsequently. And this is what happens in multifetal gestation and the ART pregnancy. It can be just, mild to moderate increase in the serum transaminases. But in acute fatty liver of pregnancy, nausea, vomiting, jaundice, headaches, abdominal pain occurring, and of course very severe malaise, fatigue, and the polydipsia, polyuria, like the transient diabetes insipidus like picture. Help, all of hypertension, proteinuria, headache, and then you have the components of health: hemolysis, elevated liver enzymes, and low platelet. Definitely it can also be associated with rash. So in addition to this, you have liver disorders independent of pregnancy. She may be having a liver disorder which anybody else can have, like viral hepatitis, primary biliary cholangitis, or sclerosing cholangitis. And typically for viral hepatitis, you will get the serology positive. And for the biliary cholangitis, you will get the anti-mitochondrial antibodies, AMA positive. For primary sclerosing antibodies, you get non-specific antibodies and abnormal immunoglobulins. Autoimmune hepatitis, the rash is quite similar. There is a itching, but positive autoimmune serology as ANA and smooth muscle LKM antibodies. Biliary obstruction, you have the obstructive jaundice as well, in addition to nausea, vomiting, and abdominal pain. And veno-occlusive disease, you can have jaundice and fluid retention. This is again a chart which will help you in differentiating the very common and very dreaded complication of pregnancy. Health, which is, you all are commonly facing nowadays during pregnancy, severe hypertension, or maybe 80 to 90% of these patients of, health, they have hypertension, but almost 10 to 15% of these patients, they may not even have hypertension. And acute fatty liver of pregnancy also can happen randomly in almost 20 to 50% of these cases. And that is why you really need to differentiate these dreaded complications from the simple intrahepatic cholestasis of pregnancy. So hemolysis is present in HELP as well as acute fatty liver of pregnancy, but it is absent in viral hepatitis and ICP. Transaminases are elevated in HELP as well as acute fatty liver of pregnancy and viral hepatitis. In viral hepatitis, in fact, they are very significantly elevated. Thrombocytopenia, all of you know, low platelet in HELP and acute fatty liver of pregnancy, also in viral hepatitis, it is very significant. But with ICP, it may not be, you will just have 10, 20,000 or up to 30, 40,000 reduction in the platelet count, which is not very significant. Hypertension, on proteinuria, I have already talked to you. Leukocytosis, of course, where you have the rapid progression of the disease like acute fatty liver of pregnancy, and when you have the infective pathology, you will have leukocytosis. Neurologic symptoms are very marked in HELP as well as, acute fatty liver of pregnancy. And they are not present in acute viral hepatitis and ICP. Now, what is the rationale of interpretation? How do you diagnose? How do you come to the diagnosis? Because you have so many pathologies. So right from history, clinical examination, now we come to the serum biochemistry. Rise in serum transaminases. I've already told you that the liver enzymes ALT and AST, they are elevated, but abnormalities in the gamma glutamyl transferase is uncommon, and it may reflect the specific subset of women. Bilirubin also you have to go for. And I have already said almost, few patients, they have a very high predisposition for GDM. Also, they have a high association with preeclampsia, so you have to look for proteinuria also. If at all you have the prothrombin time, which is prolonged, or even the epididymis prolonged, and in severe cases, this is associated with malabsorption of vitamin K. We have to exclude the obstructive biliary disease, especially when, she has abdominal pain, fever, and jaundice. So biliary sludges or cholelithiasis, gallstones, that we have to rule out. Now, what is the effect on the fetus and the mother, and how do you come to the definitive diagnosis and monitoring? So fetal ultrasound for monitoring the growth and well-being, both is important, because you have gestational diabetes and preeclampsia also. So growth, in maybe macrosomia or fetal growth restriction, both you have to look for. Liver biopsy is not required for the diagnosis. Viral serology, we have already talked that if it is positive, then it indicates the viral hepatitis. Now, how do you interpret the level of total serum bile acid? If it is more, it should be less than 19 micromole per liter. I have already talked about that. But if it is between 19 to 39, that is mild. If it is more than 40, then it is severe. If it is more than 100 micromole per liter, that is very severe. So if you have a very severe, there is an increased risk of stillbirth. But if you have severe, then of course you still have the risk of fetal growth restriction, increased incidence of preterm labor, and of course fetal distress and asphyxia events. So how do you, what are all the modalities or drugs available for the management of intrahepatic cholestasis or pregnancy? You have S-adenosyl L-methionine, which is actually it is not well studied alone, but yes, Society of Maternal and Fetal Medicine, European Association for the Study of Liver, and Chinese Medical Association have recommended it, but it is mainly in combination with the UDCA, the ursodeoxycholic acid, and this provides a better prognosis. That is what is the comment from this. Pauline phosphatidylcholine PPC. Here only 3 trials have been done, and it has been said that it provides you a beneficial effect, but at least it does not cause the adverse effects, though it helps in symptomatic relief, lowering the serum liver enzymes as well. Glutathione, there is a limited evidence to justify that glutathione is a effective and safe medication for intrahepatic cholestasis of pregnancy. Bicyclone, it is recommended by Chinese Food and Drug Administration, but there is no documented evidence. Obeticholic acid, currently there are no clinical trials, so we will not talk about it. So ursodeoxycholic acid, as we have already said, that even with the S-adenosyl L-methionine combination, it gives you a very good pregnancy outcome. So it has been recommended by ACOG, RCOG, Society of Medicine of Australia and New Zealand, that is SOMAS, and European Association and Chinese Medical Association. So all these leading organizations, they are recommending use of ursodeoxycholic acid in intrahepatic cholestasis of pregnancy. Now, what is the recommendation and what is the evidence? There is a strong recommendation and strong consensus for the use of ursodeoxycholic acid. It should be continued during pregnancy, even in primary biliary cholangitis or primary sclerosing cholangitis, as well as it is safe in pregnancy and even breastfeeding. So ursodeoxycholic acid should be considered for the treatment of maternal pruritus in intrahepatic cholestasis of pregnancy, despite having a relatively small effect on symptoms. So even though the symptomatic relief is not very significant initially, over the period it takes care of symptoms, the liver enzymes, and the pregnancy outcome. So even the Society of Maternal Fetal Medicine consult series has 53 says that we recommend that UDCA should be the first line agent for the treatment of maternal symptoms of ICP. So possible mechanisms, how does this drug work? It restores the normal metabolism of the liver, it strengthens the bile acid transport across the placenta from the fetus to decrease the bile acid accumulation. It protects the hepatic cell from toxicity of bile acids. It increases the surface area of transport organization, and of course it prevents the oxidative stress and apoptosis. So just to sum up, how does it work? You can make out this from the fetus. It is the bile acids is going towards the maternal circulation. It is getting detoxified. It has anti-inflammatory effect, antioxidation effect, hepatocyte membrane protection. So all this definitely gives you a better pregnancy outcome. So this is the algorithm for diagnosis and management of intrahepatic cholestasis of pregnancy and the role of UDCA. So if you have a pregnant woman who's got these symptoms of pruritus of pregnancy, you go ahead with the serum transaminases level and go ahead with the non-fasting total serum bile acid levels. So if you have the normal serum bile acid that is less than 19 micromole per liter, then you need not go for any treatment as such. But yes, of course, you have to repeat the total serum bile acid levels every 2 weekly to see that these levels are maintained. And only for this patient you can in fact start with UDCA to have the symptomatic relief. So continue UDCA for maybe 3 to 4 weeks so that over the period she gets a symptomatic relief. Of course, you have to rule out the other etiological factors for pruritus. Now, when you have the levels between 19 to 39, that is less than 40, 19 to 39, and 40 to 90, that is severe. So normal and mild, you can start with UDCA, repeat or reassess every 2 weekly. That is what is the way of management. If you have severe, that is 40 to 99 and maybe over 100, then of course you have to start not only UDCA, but also you have to give the vitamin K because here you need to go for the PT-INR and activated partial thromboplastin times. So if that is deranged, then you have to give injection vitamin K also. And in this situation, you have to consider for delivery as early as possible. So if you have severe, that is 40 to 99, and if the fetal gestational age is 37 plus, deliver at the earliest. Even if the fetal gestational age is lower, but if the serum bile acid levels are more than 100 micromole per liter, you have to consider delivery. Of course, if at all you find that is good and you find everything is suitable for vaginal delivery, you can induce her. Of course, you need to go for stringent intrapartum monitoring. And of course, you have to go for active management of third stage of labor. Maybe she may land up into PPH. We have to administer vitamin K. I've already talked to you about this. Postnatally, of course, you have to repeat the serum amino acids and total serum bile acid levels. You have to continue the UDCA after birth for some time, and then you cease treatment. Standard contraception advice should be advised. If at all the pruritus report recurs, then of course you may have to stop the hormonal contraception. So what is the dosage? It is said to be that 10 to 15 milligram per kg per day in divided dosage. So all of us, I'm sure, we are using 300 milligram twice or thrice a day, but that is not the exact treatment. If you have a mild disease or mild elevation in serum bile acid, then 500 milligram twice a day. And if you have a severe hypocholinemia, it is called as, then it is 1500 milligram twice a day. So usually this is well tolerated, although mild cases of nausea and dizziness have been reported. The symptomatic relief, that is reduction in the pruritus, may be seen over 1 to 2 weeks. And definitely the biochemical improvement is usually seen over 3 to 4 weeks. I've already talked to you about the dosage regime, that in very severe hypercholinemia, you may have to even use 200 milligram per day, that is 20 milligram per kg per day. So what is the evidence that yes, UDCA works? This is the evidence. This is the meta-analysis, a PRISMA compliant study, which was conducted over 662 patients suffering for ICP. And here it is said that UDCA is not only effective in the symptomatic relief or lowering or improving the liver function, but also it resulted in improvement in the maternal as well as perinatal outcome in women with ICP. This is the meta-analysis. I don't want to go through these statistics, but just to sum up, there is definitely a significant improvement in the maternal pruritus. Of course, the serum ALT levels are significantly reduced over 2 weeks, and there is a significant reduction in the bile acid levels. This is the proof. This is again, the rate of prematurity was lower in UDCA treated group than the control one. Fetal distress was much lower, almost 17% as compared to 28% in the control group. The gestational age was longer than the control group, and the birth weight was also higher in the UDCA treated group than the control group. So this is the data which says that significantly improved maternal outcome as far as pruritus and liver enzymes are concerned, significant reduction in the risk of fetal and the neonatal adverse outcome, and it may reduce the trends of premature labor, admissions of NICU, fetal stress, and neonatal respiratory distress syndrome. So UDCA is effective and safe treatment for the patients of ICP. This is again one more multicentric prospective study performed from June 17 to 19. That is 2 years of study in pregnant women with ICP attending these. These are the centers from India, the Dehradun, and all 3 centers from India. So it also says the similar one. You can see that the response to therapy is 100% showed improvement in the Pruritus, none of these patients showed major adverse effects. The liver function test improved in almost 96% of the women, and maternal fetal outcome was good in more than 90%. More than 90% they delivered vaginally with good Apgar, and of course 10% of these patients they ended up into cesarean section for independent reason. So ursoda deoxycholic acid is the accepted, safe, and preferred treatment for the intrahepatic cholestasis of pregnancy. We have a lot of evidence and we have been using it. I would just suggest that it should be used in a proper dosage to get the desired effect. With this, I thank all of you for giving me this opportunity, for collaborating with our committee, and of course, listening so patiently. So I would like to have your comments and opinion on the talk, of course. So I'm waiting eagerly to have the comments from you. And definitely, I make an humble appeal to all of you that myself, Dr. Sneha Buyar, I'm contesting for Vice President Foxy for West Zone. All of you have seen me working. I have worked for Foxy for last 21 years in various capacities and in leadership roles since last, now almost from 2017, that is 7 years. I am academically very active. I'm a successful reputed practitioner since last 33 years now. And I request all of your blessings, support, and votes for my candidature. Hope to meet with all of your expectations. And thank you so much once again. Thank you, chairpersons. Over to you.
Thank you very much, Sneha Goyal, for your elaborative, informative, and practical talk in our day-to-day practice. I am very thankful to you, madam, and Amogs team for this opportunity as a chairperson. Will definitely elect you, madam, as a vice president of Foxy. Thank you, madam.
Thank you, madam. Thank you so much. Thank you so much for staying so long and listening to it carefully. Dr. Sonia and Dr. Anita, I would.
Ma'am, I think Dr. Rajeshri Paladi have joined us overseas, so I request her comments also. Honorable Secretary Ksoga.
Thank you so much, Dr.
Madam
Rajeshri.
is I think she's in Scotland right now. I'm not sure. Madam is out of country, but she moved. Sure, she's joined the webinar. Madam.
Thank you, Anita, and congratulations, Dr. Sonia, for another very practical and the trademark talk of yours to convey the very practical and day-to-day issues to the gynecologists and obstetricians who are dealing with issues which simple problem like pruritus can really be a harbinger for many diseases that we need to face and take care. And we always have seen that in the ensuing weeks of 2 to 3 weeks, most often they land up with some or the other problem, and we need to educate our patients that yes, it exists. It is a phenomenon which we see in pregnancy, but then also to be on the alert to intensify our monitoring as far as the antepartum surveillance of the fetus is concerned, because more often than not, we also have ended up with IUDs unexplained when there has been cholestasis or itching of pregnancy. Most often we see that they'll end up in either PROM or preterm delivery or IUGR or decreased amount of liquor. So not to be taken for granted, and as rightly mentioned, the incidence is also quite high. Not to underestimate